I am Samer Mattar. I am the chair of the North American chapter of IFSO, and I am delighted to welcome you to this very exciting session that we have prepared for you. Today we have a great speaker who is going to discuss artificial intelligence and its impact on what we do on our daily lives with our patients. First of all, I'd like to thank Medtronic because they have been very supportive, and they're actually sponsoring this session. And so my gratitude to them, and also to FASMBS and James Osterhout for helping with the technical processing of this webinar. So our speaker is Dr. Matthew Kroh. He is the Chief Medical Officer of the Surgical Technologies Division at Medtronic and Professor of Surgery at Cleveland Clinic Lerner College of Medicine. He most recently served as Division Chief of Foregut Surgery and Surgical Endoscopy in the Department of General Surgery. Dr. Kroh, please go ahead and share with us your presentation.
Great. Thanks so much, Samer. Thanks to IFSO North American Chapter. I think this is going to be a really timely and fun conversation, and I'm looking to enjoy the conversation in my presentation and afterwards as well. So I'm going to be talking on AI and digital health in metabolic and bariatric surgery. From hype to safe, measurable impact and what that looks like. There's a huge opportunity in this space. I think with the number of people who are joining today, everybody's interested in what this means for us. I'll talk about a few spaces where we're seeing traction already in the surgical world and also in endoscopy. And then I think we should have a discussion at the end about opportunities where this may impact in the not too distant future. So I am a Chief Medical Officer of the Core Surgical Innovation Group at Medtronic, and I sit on these advisory boards, and I will be talking about some of these products today, but this is not designed to be promotional, and I'll talk about competing products as well. So my objectives over the next 30 minutes or so are to discuss the current state of AI and digital surgery, look at the applications in metabolic and bariatric surgery, really where there's value versus hype, and what that may look like in the next few years, and then looking beyond that for deployment of these exciting and expansive technologies. So I think we just take a step backwards a little bit. Obviously, AI is impacting our lives in many ways, from our smartphones to navigation to banking and finance sectors. And many of us have some sort of self-driving technology or automation. And really, this is an example of computer vision. And this is a real-world application. And anytime there's video and data collected, the opportunity to improve upon that with computer vision and other technologies is impactful. And of course, in metabolic and bariatric surgery, we do that every day through our laparoscopes, through robotics, and our endoscopes, and also for open surgery too. And again, just kind of looking at the big picture, AI is just getting started. It's projected that in 2027, about $151 billion will be projected in spending in generative AI solutions. And for many of the people who are attending today, look at some of the most commonly used apps that we recognize, and the time to reach 100 million users for ChatGPT was fastest amongst all these other social media platforms that are part of our day-to-day life. But the idea of artificial intelligence isn't necessarily new. In fact, it was first coined in the 1950s. And AI is really any sufficiently complex software or action that mimics human behavior for a task. It's not replication. And machine learning is enabling machines to learn and make predictions based on pattern recognition and data. And it's really more of a subset of AI, involving algorithms learning from data and relearning. And within this matrix, computer vision sits. This includes signal processing, pattern recognition, image processing. And generative AI is a type of AI that can create new content. And there are many examples of this, original text, images, music, and video, and so forth. And we see this increasing in popularity across nearly everything that we do. So where do we sit currently? And what are some kind of immediate opportunities? So there are opportunities for advanced imaging techniques, for better diagnosis and precision, structure detection, anatomic structures and pathologies. And in the surgical world, this is being built into different platforms that use computer vision and capture images, whether that's robotic laparoscopy or endoscopy. And I do want to touch on the endoscopy space because in some ways that real world data is accruing faster than in our surgical space, but it can give us some glimpse as to what that looks like in the not too distant future. So opportunities in the upper GI tract and the lower GI tract, and I'll talk about a few of these examples, and then total tract as well. And it's interesting. So some of the conundrums that we talk about for AI and applications come out in some of the data that has accrued. So this is a study looking at real-time upper endoscopy quality assurance. And this was a metric just to make sure that the entire mucosa of the esophagus, stomach, and the first part of the duodenum was seen. And using real-time quality assurance, that blind spot reduction was reduced significantly. Obviously, this is real-time feedback, may ensure quality, but if you're doing an endoscopy or a procedure just to get to a metric, it may actually be distracting from whatever real reason you were doing that. And you may be so consumed about showing all of the mucosa that you may not be really doing an endoscopy for whatever that indication was. Really an undue attention to a target that may or may not be meaningful. But there are huge opportunities in endoscopy. Barrett's, the quoted miss rates may be up to 20 to 40%. In the United States, gastric adenocarcinoma is often missed as well. And the ability for AI to exceed human performance in visual interpretation is significant because any GI endoscopist or surgeon may see thousands of cases versus millions of data points that accrue in the existing literature. And specifically looking at Barrett's, looking at an expert endoscopist plus AI versus a novice endoscopist with AI, accuracy, sensitivity, specificity, it helps everyone. And to varying degrees may be more helpful for the novice endoscopist. But if you look at AI alone, those numbers for accuracy, sensitivity, and specificity are in the 80, 90%, and then specificity at 70. So that's pretty compelling that AI alone is comparable to an expert performance. And in addition to that, this is looking at, again, Barrett's sensitivity, specificity, endoscopist, AI alone. Those numbers at least are comparable, if not better. But this study really pointed out to me the speed at which this can occur, fractions of a second versus nearly a minute. So this is very compelling in terms of workflow and time spent identifying these diseases. So one of the best applications currently is detection of colon polyps. Obviously, we know that colon cancer is the #2 deadliest cancer. We know that it's preventable if caught early, and that's the entire motivation behind screening colonoscopy. And they can be hard to detect. In that video there, you might not have noticed that there was a polyp sitting there. And polyp detection obviously is real time. It helps for detection and diagnosis, relies on computer vision, and does increase adenoma detection rate. The cons of it, of course, are that it requires an additional skill to incorporate this into your workflow. There's not a reimbursement mechanism and so forth, but we can imagine how this could be really important because the data shows that in more than 20 randomized control studies, nearly 20,000 patients, the absolute increase was about 24% in increased ADR, 44 versus 36%, with an inspection time that only increased by half a minute or so. So that's super compelling. And I think that even in our metabolic and bariatric surgery space, the applications in GI, we can imagine what that looks like. But if we think of this concept of a digital ecosystem in digital surgery, what does that mean? Well, obviously computer vision can help in the operating room, but in the long term, the goal would be to reduce complications during surgery, decrease variability, and generate vast amounts of data that can be interesting within a department of surgery, applied to a large database, and so forth. So those are the real opportunities. And some of the applications in surgery so far have been in structure detection. There are programs that look at metrics of surgery like bleeding and tissue injury, and algorithms that can be trained on this to look at intraoperative adverse events that can be captured. Currently, this is really based on routine tasks, and there's a relatively narrow conceptual framework, but there are a lot of applications, and probably the best known of this is the SAGE's Critical View of Safety Computer Vision Challenge, which is looking to gather data using computer vision algorithms to ensure or diminish the risk of common bile duct injury. And this is an ongoing data accruement that obviously has a huge implication for safety and performance of cholecystectomy. So when we think about that digital surgery ecosystem and how all of these inputs of data are collected, again, it can be in a laparoscopic, it can be an open, it can be an endoscopy, but the robotic surgery enthusiasm is really allowing this digital surgery advancement to take place. Obviously, robotics has been around for more than 20 years. It's penetrated all subspecialties, including metabolic and bariatric surgery. But we're on the verge of having many more applications in robotic-assisted surgery that may be able to sit in different settings, different geographies, and different price points. Obviously, Intuitive has been the market leader for more than 20 years. The Hugo RAS system from Medtronic is not commercially available in the United States, but is available in more than 30 countries around the world. Data is accruing with this. This is a kind of larger platform robotic system, but there are many kind of purpose-built robotic systems too, all of which will help us facilitate doing operations, but are opportunities to collect data as well. And the digital surgery ecosystem that's integrated with robotics really is an ideal interaction to capture massive data sets, not just of imaging, but of kinematics, instrument exchanges, and efficiencies, which ultimately, hopefully, will lead to improvement and performance of operations. And there are multiple inputs from this. But in addition to that, integration of advanced imaging, mixed reality, artificial reality, and then other imaging modalities, may improve the performance of robotics. And what does that look like, and what are the implications? And you might think, well, where are we as surgeons in this AI revolution that's taking place? As technicians, maybe we're the most safe to be not replaced in the near future, and that's probably true to some degree. But the group from Johns Hopkins has actually demonstrated with a robotic platform high-level anastomoses. Obviously, there's laparoscopic setup and so forth, but already these are being applied in situations that you might think be really challenging for an autonomous robot to be deployed. Of course, this is super early, but just something to keep in your mind as we look at the not too distant future. But digital surgery platforms have huge opportunities, and to some degree we know this already. Post-operative debriefing, coaching, surgical education, quality improvement meetings and processes. But capturing this and reviewing it takes a lot of effort when it's manually done. But the Michigan Bariatric Surgical Collaborative showed that video-based assessments can shorten the learning curve in metabolic and bariatric surgery. And I think that we all know this when it is given in a way that is understandable to trainees and new surgeons, that there is immense benefit from video-based learning. But why now in metabolic and bariatric surgery? Well, we have a very unique specialty amongst our general surgery brethren. Is still relatively new, and many new procedures are being introduced. Revisional procedures, conversional procedures are becoming more common and complex. And there's huge variability around the world in terms of deployment of surgical treatment of obesity. The medical workforce and cost pressures are important, documentation burdens for all that we do, as we have these conversations, talking about equity gaps and uneven access to quality care, there may be an opportunity within systems or globally to kind of level the playing field in these spaces, which is really fascinating. And we're all super busy. The majority of surgeons believe that tech limits them from performing at their best. Inefficient technology adds almost 4 hours a week, and 70% of surgeons are spending time outside of the hospital on some sort of administrative task, all of which with new technologies may be done in a faster and more efficient way. And this is really working with clinical workflows. So, opportunities in real-time use of natural language processing and generation for outpatient notes is taking place already. We do that at the Cleveland Clinic. Improve speed, reduce workforce, maybe better billing opportunities, efficiencies. And this has really changed the way that we've practiced. Additionally, there are technologies that can identify with biomarker technology, with short, unstructured clips of speech to identify diseases such as mental health disorders. And many of us may not be great at pursuing this in our busy interaction with the patient, but using these technologies may allow for a patient to seek out care that they may not otherwise get because we simply can't recognize that in a patient. So if we think about this intelligent surgical ecosystem, how is it going to transform surgery? Well, in the preoperative setting, image preparation, consolidation into our surgical plan, training videos, and so forth are immensely important. We already talked about the robotic-assisted surgery. Doesn't have to be, but often is the centerpiece for intraoperative smart instruments in the future. And we'll talk about that a little bit more in the next few slides. And then postoperative review, video management and analytics, and then comparing that to outcomes may be a true opportunity for us to get better at what we do. So what does it look like? For preoperative planning, and this is really thinking out loud, and I'll be curious what everybody thinks about this in terms of opportunities, but imaging assistant assessment, liver size, abdominal wall hernia, and so forth, risk stratification, better than we do now with MBS QIP. And then large language model assisted intake, comorbidity capture, and so forth can potentially do better jobs of this for us. Increasing access and navigation in the pressures of effective GLP-1 agonists. We need better efficiencies for the most durable intervention for obesity, which is surgery. Potential roles of education bots, multilingual navigators, waitlist triage, and remote qualification steps for patients to reduce time to surgery. All can be opportunities with this technology. And at the end of the day, really, video is the cornerstone of digital surgery. So whether that's workflow analysis, the ability to segment an operation into 8, 10, 15 different steps for review in real time, instrument detection and tracking for efficiencies of movement and improvement of performance of surgery, scene segmentation and reconstruction, obviously very important to what our specialty looks like, and then critical structure identification. We can think about how all this, may be applied to metabolic and bariatric surgery too, but these are the technologies that are rapidly entering into our space. So for intraoperative decision support for metabolic and bariatric surgery, you could speculate that might be around bougie visibility or calibration confirmation or staple line integrity cues, institution of pause points and checklists. We know that before we start an operation, this can be valuable in terms of improving safety for patients, but over the course of an operation, that also can be important as well. And there are opportunities to do this. Today, we're using AI to transform videos into actionable insights. This is the Touch Surgery platform, which will take your operation, segment it into identifiable chunks, and then compare yourself to what you historically have done, and then others in the system too, to benchmark yourself across a bigger network. And the implications in a large healthcare system are obvious, but for your own process improvement, I think this is valuable too, and a really unique tool. Postoperatively, there may be opportunities for predictive alerts for complications of surgery, chatbot-guided symptom checks and nudges from patients at home, and then home monitoring for all these outcomes that we know are so important, PROMs, vitals, weight loss trajectories, and so forth. And that's in the immediate post-op period. But what does that look like longitudinally? There may be opportunities for personalized weight loss curves, early deviation detection, tailored nutrition and behavioral intervention, and opportunities to link all of this data to big databases that we've constructed so well, MBS QIP and IFSO databases, to actually really see if these interventions result in better outcomes. And data is accruing in the space already. So our group at Cleveland Clinic looked at machine learning prediction of major adverse cardiac events after elective bariatric surgery, looking at MBS QIP and using several different models to look at this with maybe better modeling than standard logistic regression. And we've also looked at using large language models engulfing guidelines and statements in creating AI for bariatric surgery, both at clinician level recommendations, so maybe not for bariatric surgeons, but for our colleagues in endocrinology or internal medicine, and then also looking at performance of AI in a comparative analysis and the textbook from FASMBS as a resource for trainees. So these are huge opportunities in this space. And I also think that we should talk about this to some degree, and I know that Scott will be interested in this, but what are the roles of writing scientific literature in 2025? Drafting support versus ghost authorship, reference integrity, hallucinations, these are all part of using AI tools. And how do we identify this and make sure that the best science is being put forward? Additionally, this digital ecosystem has a huge opportunity in training. For years, we have relied upon numbers of procedures performed to be a baseline metric for efficiency and completion of fellowship, and volumes are a metric for quality to some degree, but it may not be. And AI may allow for standardization to see where you really are performing compared to your peers, learning new techniques and technologies. So it no longer is volume or years performance against known metrics. And we can identify personalized training plans if we do this compared to large data sets. And performance matters. And we know this already, but there is data accruing this. There's a study in Annals looking at laparoscopic gastric cancer surgery, and technical performance is an independent predictor of post-op outcomes. And this has huge implications because it's really hard to explain in terms that surgeons understand what this means. There are implications and roles for credentialing, potentially certification or recertification, and then ultimately linking this to outcomes databases will be super compelling long term. And I think we all need to be part of this conversation as it moves forward, because current state has challenges and limitations. There's data privacy concerns. We need to make sure that we're getting diverse training data sets to make sure that there's algorithmic fairness, not reflective of data input and bias or geographic variation or socioeconomic status. And there are all these wonderful technologies, but how do we actually integrate this into our medical infrastructure and workflow? Well, it's going to require physician oversight. So we need to be part of these conversations. So at the end of the day, will algorithms and robots take my job? No, but it's changing rapidly. And we as surgeons need to understand the real value added, and are we including technology for patient betterment at the end? Additionally, there are ethical considerations which are fascinating. How do patients consent to entering their data into these big data sets? And ultimately, if there's a complication, who is responsible? Is it the surgeon? Probably. Is it the device? Is it the algorithm? These all are ideas that we need to work through. And these machine learning biases are really black box algorithms that can't be deconstructed. We can't go into the pathway to explain to people how that decision came up. And there are different degrees of what these artificial neural networks look like: supervised, semi-supervised, and unsupervised, and so forth. But to some degree, these aren't really explainable algorithms necessarily. So in conclusion, and then looking forward to a robust conversation afterwards, AI is fundamentally changing society and medicine. It's relatively nascent now. The opportunities in this digital surgery ecosystem around computer vision, agnostic, cloud-based protected image capture and analysis hopefully will allow us to improve care delivery, quality, and safety, and in a spectrum of ways that I think I've touched on today. And in some ways, the GI endoscopy space is kind of leading, and we have a lot to learn from that space. So I'm immensely grateful to IFSO, North American chapter, for the opportunity to speak today. If you have an interest in these technologies, the Cleveland Clinic puts on an emerging GI tech and surgery forum. It's web-based and quarterly, and these are some of the topics. This is a link if you want to get some more information. But I am immensely grateful for the opportunity to speak today and look forward to a conversation afterwards. Thanks, everyone.
Thank you, Dr. Kroh. That was a very nice, comprehensive overview of artificial intelligence and its role, its emerging role, if not actual present role in metabolic and bariatric surgery, in fact, in all of the house of surgery. I think this is a revolution no less important than the Industrial Revolution. It's going to change all our lives. Let me take an opportunity here to introduce our star cabinet of panelists. We have my co-chair, Dr. Radu Pescarus. He is an associate professor of surgery at the University of Montreal. He is the co-program director of the minimally invasive bariatric and metabolic fellowship at Sacré-Cœur Hospital in Montreal. And he currently serves as president of the Canadian Association of the Bariatric Physicians and Surgeons, CAPS. Thank you for being here. We also have Dr. Thomas Shin. He's an assistant professor of surgery at the University of Virginia School of Medicine and surgeon scientist with active research interests focused on integrating artificial intelligence and machine learning into surgical practice. Thank you. Dr. Jaime Ponce is the medical director of bariatric surgery and obesity medicine at Park Ridge Health Center. He is past president of FASMBS and current president-elect of IFSO. And thank you all for coming. I'm looking forward to a robust conversation and discussion about what we just listened to. As for the participants, welcome. I know you're here from around the globe, different time zones, and I really appreciate you attending. There is a chat box on your screen at the bottom. If you have any questions, please feel free to enter them, and I will keep monitoring. We all will, and answer the questions accordingly.
Hey, Summer,
yes.
Introduce Dr. Shikora as well.
No respect, no respect at all.
Oh, I am sorry. And of course, no, Dr. Shikora needs no introduction. Everybody knows Scott and his accomplishments. He is professor of surgery at Harvard Medical School. He is past president of the American Society for Parenteral and Enteral Nutrition. He is past president of FASMBS, as well as past president of IFSO. He is also the current editor-in-chief of Obesity Surgery. Welcome, Dr. Shikora.
Thank you.
I'm delighted you're joining us. I wanted to kick this off, Matt, because you covered a whole lot of ground, both in the clinical arena and also importantly within the operating room, and in the clinical, both, you know, the entire like peri-operative or the entire continuum of care of patients and how AI might contribute to that. I think the box that we would really like to unlock is something that we've been struggling with ever since the dawn of bariatric surgery, and that is how to select the patient to the operation. Right now, we have 2 or 3 very common operations that we kind of offer to all our patients with some minor differences for indications. But do you think one day we might personalize it a little more and select patients so that they might have the best possible outcomes?
I do. And I also think that these technologies will disrupt the kind of step up treatment that we've always thought about, diet and exercise, medication, endoscopy, surgery, but that is not a linear pathway anymore. And our field is so dynamic. You're right. I mean, there's 2 or 3 major operations that we offer the majority of our patients, and they do great with that. But with the innovation, there's so many variations of those operations. So there's a few thoughts. I think the answer is yes, but we need to continue to capture data on what these outcomes look like in the short, medium, and long term to better analyze who's going to benefit from what. So that has always existed. We may have new opportunities to look at this in more detail than we did in the past, but obviously a huge opportunity in this space.
Thank you. And if anyone has any questions, please go ahead and ask. Another area. So with now let's enter the operating room domain. And as surgeons, we always face questions while we're operating. For example, incidental findings of a hiatus hernia. That's not necessarily huge. Those are easy to decide on whether to repair or not. But I'm talking about the more subtle ones, the more marginal kind of hiatus hernias. And it's sometimes hard to really make a decision on whether to repair or not. Do you think that AI programs will be able to, in the future, recommend to the surgeon, yes, go ahead and operate this because the chances are such and such probability of this patient getting postoperative GERD?
Yeah, I think there's definitely opportunities for that. We need to look at translational data to see what that means. I mean, obviously sometimes even the data on fixing a hiatal hernia is a bit mixed. But the implications for individual patients with preoperative demographics, intraoperative computer vision to see what that looks like, the actual size of the hernia, the laxity, the likelihood that are the pillars relatively robust, and what operation are you performing? I think that all of those go into real-time decision-making and certainly could be an application. And, the other thing too is that you have data around some metrics of what we do. Obviously, for a sleeve gastrectomy, for instance, we have a dilator of certain sizes that we know that once it gets too small, GERD rates go up and stenosis and untoward outcomes can occur. And if it's too big, weight loss may not be great. And gastric bypass, if the pouch is too big, you may be at more risk for, anastomotic complications. And I think that there's an opportunity to use computer vision in this smart digital ecosystem to identify maybe where your stapler should go. Maybe you nudge it over another centimeter to make sure you're performing, in the middle 50th percentile for what a sleeve gastrectomy should be. I mean, we're far from that, but these are the types of opportunities that we have for technical process improvement.
Thank you. Jaime, Dr. Ponce.
So, Matt, I'm gonna throw this a little bit more controversial and futuristic. So you kind of determined that AI is very good for visualization. You can identify things much better. So potentially reading a CT scan, radiologists will be eliminated there. Pathology, reading an image may potentially eliminate that need for that pathology reading. I was able to participate last year. We actually presented this abstract in the FASMBS last year on deep learning system to identify 13 steps on laparoscopic gastric bypass. And AI was able to identify in most of the times the steps after several cases, an average of 50 to 70 cases, identify clearly. You throw another video and I was able to identify all the steps. So potentially in the future, let's move on to years ahead. Do you think this robotic arms are going to be able not only to identify the steps, but able to do some of the steps of the surgery or do the surgery?
Yes, but that's a stepwise process. The Hopkins group has already demonstrated autonomous anastomoses with some significant laparoscopic setup, but the ability to automate certain processes I think isn't a huge stretch. For instance, maybe there's a robotic opportunity with computer vision to close trocar sites more efficiently than what we do now. Like simple process, not to divide the stomach or do an anastomosis, though eventually we'll get there. So there will be automated steps that will start with, bits of an operation and then supervised steps. Maybe you put the stay stitches in, there's a blue stitch and a white stitch, and then the robot will complete the anastomosis. So, there's a stepwise approach to do that. It's not hit a button, do a sleeve gastrectomy, robotic automation, but you'll see the certain tasks may be better performed in an automated robotic way.
Agree.
Thank you. Dr. Shin.
So Dr. Kroh, thank you so much for that great overview and talk. Along the same vein, I want to ask you something controversial as well. I totally resonate with your perspective that, there's a digital surgery revolution. For obvious reasons, the robotic platform is conducive to how we can integrate AI into metabolic and bariatric surgery. But I know for a fact that you and the rest of the panelists are master laparoscopists. So how does that fit into this transition? Are we facing some kind of complete modality revolution, or are we still trying to figure out how we can intersect AI digital surgery with analog methods of minimally invasive surgery?
Well, it's a great question. I think we have to have solutions for every approach, whether that's open laparoscopy, robotics, or endoscopy. So there's an opportunity to enter all these spaces. It just seems that robotic is the ultimate image capture device currently, with massive amounts of data that are routinely taken. But the technologies should be agnostic to platform, and the implications should be worldwide, because there won't be robotic surgery in every country around the world in the immediate future. So, and we want to make sure these technologies help all surgeons. So I don't think it has to be specific to robotics, though that seems to be the centerpiece of the digital surgery ecosystem currently.
Thank you. Dr. Shikora.
Well, great talk, Matt. I learned a lot. I've been kidding around tongue in cheek if we have any discussions about AI, saying someday I can anticipate that you load the data into a computer and the computer does the operation for you because it just follows the script. And I don't believe it any less now than I did a few years ago when I used to kid around saying it. This discussion sounds very much like the discussion we had one day 20-something years ago when laparoscopy was just on the beginning, on the forefront, and we were all looking for how to use it and how's it going to be safe and all that. And we've come all this way. I think we'll see it again with AI.
I do, but my kind of call to action for everybody who's listening today is that we all need to engage in this. Don't think it's going to not apply to you. It will in some way, shape, or form. Whether that's ambient notes in the outpatient clinic, there will be application. So we as surgeons and as societies need to be engaged in this conversation to make sure the technology is deployed in a way that's meaningful for us as surgeons and our patients, most importantly.
Again, that's exactly the discussion we had with laparoscopic surgery in the beginning, where there were those older surgeons who didn't learn and didn't want to do it and was bad-mouthing it. But now you can't find a surgeon who doesn't do laparoscopic.
Thank you. Dr. Pescarus.
Thank you very much, Dr. Kroh, for a thought-provoking presentation here. I just wanted to ask a question about this new concept of collaborative intelligence. I think you and Dr. Shikora co-authored an editorial recently in Obesity Surgery, talking how we can combine not only AI, but also add this human intelligence aspect. And I think you mentioned that we'll know a little bit about the potential limitations of AI. Would you be able to comment a little bit how we can combine this, our surgical experience as surgeons with the AI tools, and how this could get us over some of these limitations of AI?
It's going to be an ongoing conversation for all stakeholders. How do we deploy it? What is a meaningful outcome? For instance, if we can gather enough data to look at segmentation of gastric bypass, and then start to put surgeons in certain percentiles of performance, even just for efficiency of movement. Ultimately, linking that to data is super compelling. But these are the sorts of metrics we need to start thinking about. All of us think that we're outstanding surgeons and perform in the 95th percentile, but we're not. And it's okay to be in the 30th percentile because your major complication rate may be clinically insignificant from the 70th percentile, but there's an opportunity for that first and second percentile to get better. And when we have this data, we can be much more objective about what those conversations look like and the process improvement. So to answer your question, we need to be a part of this, deploy it sensibly and engage. And as industry moves forward quickly, again, all stakeholders need to be part of the conversation.
Thank you. Dr. Ponce.
So taking advantage that Dr. Shikora is here with us, Scott and Matt. So different topic, using AI not only to write a paper, but to review a paper. That's becoming very controversial and very tricky. And I know that Scott is dealing with that all the time, because to identify if a portion of the paper, all the paper was written by AI. And not only that, the reviewers are using AI sometimes to review the papers. So any comments, Scott and Matt, about this?
And if I might add to Jaime's very timely, very important question, you did briefly touch on this, Matt, and I'm delighted that Dr. Shikora is here to address this. But as you know, a lot of our papers, a lot of position statements, a lot of guidelines are based on the papers that Jaime is referring to. And these are influential because they are read and digested by multiple stakeholders. And as you know, Matt, with great power comes great responsibility. Spider-Man taught us this many years ago. And so, Scott, tell us, what are your thoughts on this looming, powerful technology that is now available?
Well, it's an issue for us on many levels right now. First of all, Springer does not accept anything that's AI. And Springer owns 10,000 journals around the world, including obesity surgery. So right off the bat, and trying to introduce it as a player to collect data or to help you write the abstract, whatever the case may be, that's out. And there's algorithms now where they can catch some of the people using AI and then penalize them accordingly. But is all AI bad? I'm not so sure. I would think maybe you can use it to do the research to write your review, even though you're not going to use it for your review. That's a possibility, although, like I said, Springer is against it right now. I can kind of tell, I think, looking at the comments that come back from the reviewers, as well as the comments that go from the authors to the reviewers, I can get a sense which ones I think probably are AI, because they're often 30 pages long, where the normal review might be 6 pages. And the terminology that's used and the way that it's shaped, just the visual, it looks like, a higher authority was working on it. But it is going to be a problem for us. Is it plagiarism if one of you guys uses AI to help you just make your paper better? Don't know the answers to those questions yet, but I know the questions.
Yeah, it's one of these cases where the situations where technology has advanced much faster than our ability to manage it, isn't it?
Yeah.
Well, it's the same as driving a car without a driver, and the laws, are still very unclear what happens if the car commits an accident or do this and that, and who is responsible for that if there is no driver. So I mean, there's just a lot of this technology is taking further steps before we regulation
Yeah,
change.
to add to that, Jaime, it's not so much the concern of the driver because the car is automated. The concern is the people driving a regular car that hits a car that's a self-driving car. What happens then?
Yeah. And you mentioned this, Matt, in your talk, that unfortunately and unwillingly, bias enters into these algorithms. And so what I was alluding to earlier about several stakeholders, policymakers and insurance payers, and there are many other people who might receive these findings or conclusions that are inherently biased, and then maybe exclude certain people from life-saving procedures.
For sure. So, those data sets need to be broad, diverse, and generalizable. And, that it's obviously very regional specific too. A lot of that data that's being collected represents North America and Western Europe and not the world. So we have to be aware of that as we continue to construct these data sets.
There's a question in the chat box from Claudio Holanda in Brazil. He's asking, Dr. Kroh, I'd like to ask your opinion on the possibility of integrating pre, peri, and postoperative data across hospitals worldwide to achieve better standardization in bariatric surgery. Do you think this could help us move towards more individualized and consistent results?
I think it's a huge opportunity. Obviously, it's a mountain of work to make that happen. But that's the goal, is to move the needle forward around the world to identify best practices, whether it's around the technical performance of an operation or postoperative management or complications, or even following patients longitudinally. If we find that best practice, now again, there will be regional variability, but there probably is a best way to do this in each geography. And these big data sets will let us at least have some cue as to what that could be.
Yes, but bear in mind there's a pretty big bias that's going to go along with it. Cleveland Clinic is a leader in this field and probably going to publish a fair number of papers and hold your meetings and all that stuff. So that data is going to reflect the data from a large center when there's many, many other smaller centers that won't have that same data.
I'm thinking of what's happening over the last 20 years, in which there's been an increase of administrative tasks for a physician to practice. Correct? We have now more billing, more collection, more documentation, more stuff to do. And that has made the practices, private practitioners, moving to hospital employees because there's not a lot of money available to pay for all those tasks. And that's increased the shift. You can see any data, many physicians are going to hospital employment. Would that change in the future by having AI taking over all those tasks? They do the billing, the collection, even virtual assistant that can answer the phone, that can make appointments, that can talk. I saw a virtual assistant that looks like Dr. Smith in Texas. Same thing, virtually and then talks like him and all this stuff, and then welcomes them to the practice. So there's the potential of having all these tasks done by AI will decrease the expenses, and then eventually, even EMR and all stuff, will get better, and then maybe the practitioners will get back to private practice. Interesting, huh?
Agreed. And I can tell you that many, for us in North America and other places where they have insurance, many insurance companies are already implementing AI in the decision-making process. And I think we're all experiencing, variability in that. We've been talking about surgery a lot, Dr. Kroh, and one area that's very important, of course, in what we do is integrating pharma, integrating medications with our patients. And I wonder if the big pharma companies, they're having all these clinical trials and post-market surveys and data collection. Is this being collected by AI? And do you think that one day it'll help us better integrate both the timing, the nature, the amount of obesity medications in our surgical armamentarium?
Yeah, I think absolutely. Obviously, surgery remains the durable pillar for treatment of obesity. But when we institute that therapy, may be highly variable with an ever-growing pharmacotherapy portfolio available for treatment, in addition to endoluminal therapies and exercise and diet adjustments. Like all of that will go together that I think will be personalized, and it will no longer be kind of a step-up approach or a linear progression from kind of least invasive but least effective to most invasive and most effective. That's a different answer for, a 32-year-old woman in North America versus a 75-year-old man in the UAE. Like, we're not that sophisticated yet, but I think that will give us some insight as to who will benefit from what therapy from an effectiveness standpoint, but also from a cost efficiency standpoint over the lifetime of treating patients in a chronic progressive disease like obesity.
Great. Nothing in the chat box. So let me ask you the role of AI back to the operating room. We talked about how it can analyze video recordings of our procedures and give us commentary on that, on how to improve the next time. But do you think it will ever move a step ahead of that and become an intraoperative in real-time mentor? Let's say I'm actually, closing an anastomosis, suturing an anastomosis. Will it be able to tell me, maybe this isn't the right suture, or maybe if you held it this way or the needle that way? In other words, assess in real time how I'm closing a mesenteric window, how I'm anastomosing.
Yeah, I think we'll get there. That's the great hope. I think real-time intraoperative decision-making will initially focus on kind of no-fly zones or identification of critical structures or significant errors, like common bile duct during laparoscopic cholecystectomy. But will it get more nuanced to say, use a permanent suture in a running, locking fashion to close the mesenteric defect, and your bites are too thin? If this patient loses 100 pounds in the next 6 months, that's unlikely to stay together. I think we'll get there, but it will require a lot of data analysis and then linking to outcomes to make sure that it's meaningful.
I had a quick question related to that, Dr. Kroh. So I think there's a lot of trepidation among my peers, I guess, with regards to exactly that point, linking metrics or elements of digital surgery to outcomes. So could you expound a little bit more on that, and perhaps for those of us who are much more junior in surgery and research overall, as someone who kind of plays that dual role of surgeon investigator and your work at Medtronic, like what kind of relationship do you foresee academic surgery forging with industry as we kind of move along this progression of how AI can help augment outcomes?
Yeah, it has to be a partnership. You're absolutely right, Tom. I think that the technology will be developed and applied to wherever, but it will be up to surgeons and societies and other stakeholders too, payers, credentialing bodies, to figure out what that means and what the implications are. We have to be careful with this, though. You can imagine in a simpler example, we don't want to limit access to care. A patient may want to go to Virginia to have a gastric bypass with you because you operate in the 95th percentile, and they may not want to come to Cleveland because I operate in the 45th percentile. And those percentiles seem vastly different, but the readmission rate may be fractions of a percent that are not clinically meaningful. So we have to have clinician oversight with what this means. Ultimately, linking to outcomes will hopefully help guide best practices, but we have to be cautious about how those messages are delivered.
Matt, what about something more simplistic like a job interview? Show me your video. And not only that, AI reviewing videos of different candidates and then telling you which one is better and which one is not.
Sure, and that's pretty easy to do. The Michigan Bariatric Collaborative did that with video-based assessments. It's incredibly labor-intensive to sit there and look at those.
Mm-hmm.
But if you could aggregate an entire fellow's year of 400 cases and then drop that into some sort of percentile, you might have an idea of how that fellow might do. The flip side is you might just say, all right, fine, pick your top 10 gastric bypasses, and this is part of your video CV. And you could run that against an AI algorithm and say, this candidate performs in the 40th percentile. Do you want to hire him or her?
That's very intimidating for
just
candidates, no?
ability to do gastric bypass. It's do you get along with the nurses? Are you a good teacher for the students? You'd have to figure out how to fit all that in as well, some of these soft issues.
I feel the anxiety of Tom and the younger surgeons, because there's a lot more than just that video, and the video may be used in a very different way than what the person is. The person can have an assessment and a better clinician, and that assessment comes from the mentor or the director of the program much better.
Yeah. I think surgeons are by definition trainable, or they should be. And if I do find, I don't know how much weight, back to Scott's point, how much weight I would put on just getting a score from a video, because we can always teach this even junior faculty, how to improve time. How do you see AI developing in the integrated health section? Very quickly, we've got a couple of minutes left.
Huge opportunities. I think in every aspect of patient care, there will be applications. So remote learning, educational tools, I think are part and parcel to every aspect of treating patients with obesity. And much of what I talked about, maybe not the technical performance of an operation, but everything else in terms of access, throughput, risk stratification also would be applicable to integrated health.
Well, thank you very much, Dr. Kroh, and all the panelists today, Dr. Scott Shikora, Dr. Tom Shin, Dr. Radu Pescarus, Dr. Jaime Ponce, for a very stimulating, very exciting discussion about a very hot topic that is here to stay, obviously, and I have no doubt in my mind is going to have tectonic changes in all fields of surgery, including ours, which desperately needs some more information to try to personalize our treatments. Once again, thank you all very much for attending. And for the participants, this will be recorded and it will be available for you. And I look forward to hosting the next webinar.